actually. Oh, I can maybe. So yeah, if you have any questions or just have anything to say, just shout out or put your hand up. It's quite an informal talk from me. The title doesn't really give much of it away, but as Teddy said, I've been working a little bit in data science and also a public health registrar, um, from one state to another. So hopefully that will sort of make sense by the end of the talk. So yeah, so a bit about me. So as Teddy mentioned, I've been sort of a background in medicine, working in a bit of data science and public health. So what I'm going to talk about today is a bit of an intersection of all of this. So it might not be hugely relevant to what you guys do, but hopefully you find it interesting. Be talking about multi-state modeling in the context of health economics. So giving a little bit of an insight into what some of these decisions involve. Maybe you work in this area, maybe this is completely new, but either way, I'm not an expert. This is something I'm learning about on the go, but I thought it'd be really interesting to share with everyone. So multi-state models, this is an example of one. It's essentially looking at different sort of health states. So healthy, sick, sicker, dead is an example. And a particular way to model this is called Markov modeling, which is what I'll be talking about. And there's some more Markov models that kind of depict my sort of transition through different parts of medicine, and my transition through learning about health economics. Okay, so if I were to ask you, this is quite interactive bit, by the way, how you would decide between, so you're sort of head of an ICB deciding what interventions might be plausible or useful in your area. In terms of health economics and cost effectiveness, how would you decide between two completely different interventions? So we can look at an intervention, for example, that reduces mortality in hip fracture reductions, versus an intervention that maybe improves outcomes for people with depression or anxiety. How would you compare these? Like, what sort of questions might you ask if you were the one deciding which one to implement?
Quality adjusted life year sort of measures.
Yeah, Teddy said quality adjusted life years sort of measures.
It's not an easy question, I guess. You have to make a big judgment.
Yeah. Yeah, that's a good point. There might be some value judgments involved as well. So yeah, you might ask about costs, outcomes, and as Teddy mentioned, quality adjusted life years, um, impact as well. And one I didn't put on there is value judgments. So how do we value health? How do we value different types of health? Um, and so ultimately, this leaves us with a decision problem. How do we maximize the health benefit from the health system budget? So we know we've got a finite set of resources, we've got a finite budget, and how do we decide which interventions are best value for money, are cost effective? So yeah, as you said, we might be asking, what does cost effective even mean? How do we distribute the finite resources in an equitable way? What about long-term outcomes? So we know things might be effective in the short term, but how do we model long-term outcomes? How do we model long-term costs? Should we value health in monetary terms? How do we measure health benefit? And do we all value health the same? One person's hip fracture reduction might be more important or more valuable to them than another person's treatment for chronic kidney disease. So it's very sort of person dependent, but how do we maximize this on a population scale? So one way to approach this decision problem is economic evaluation. Just to get an idea in the room, has anyone been involved in an economic evaluation sort of in their area of work before? Okay. If yes, please do shout out and help me out because there's quite a lot to it. So I'm hoping to give you some.
Put in a chat about demographics of the catchment area.
Oh, nice. Yeah, demographics of the catchment area. Yeah, who are the population that we're trying to serve? Um, okay, so what is an economic evaluation? So by definition, so if we're talking about cost effectiveness, it's a evaluation of comparison. So we need to be comparing one intervention, which is normally standard care, with a new intervention, which might be your new sort of up-to-date, I don't know, medicine, or a new intervention to optimize falls prevention or something like that. So we have to be comparing it to something else, which is usually standard care at the time. Cost effectiveness analysis also take into account both costs and consequences, and we'll talk more about that because Teddy mentioned the quality adjusted life years. So I've recently learned what those are, what those actually are. And they look at multiple perspectives as well. So if we look at NICE guidance, so NICE are commonly the people who use economic evaluations in health technology assessments. And they have like a set guideline of what they look for in economic evaluations to deem them acceptable in their perspective. And so different types of perspectives could include an NHS perspective. So that's looking at cost and consequences directly for the NHS at an individual level. Or we can look at something like a societal perspective, which has a look at the costs and consequences of a wider impact. So, for example, let's say if we are looking at improvement to a hip fracture procedure that reduces mortality, we might say, obviously, at an individual level, that person can then sort of go back to work quicker potentially, and sort of contribute back to society, and sort of have a better quality of life. But looking at a societal perspective, it might also take into account, well, actually, that person might not need a carer for as long. They might not need transport or help to get to work for as long. And so it sort of looks at the benefits outside of just that person, and actually you're improving the well-being of the others around them as well. And the other big sort of aspect of cost effectiveness analyses is incremental cost effectiveness ratio. So because we're comparing one intervention to another, we then look at the increments of the difference between the cost effectiveness, and this is a ratio because we're comparing costs and consequences basically with new and old treatments or interventions. So you might say, so cost effectiveness is essentially saying what is the cost to gain one more unit of health? But what is a unit of health and how do we measure it? Might be something you'll be asking. So Teddy, maybe do you want to, you mentioned quality adjusted life years.
Yeah.
Did you want to tell us what you know about it? Or sorry to put you on the spot.
Yeah. The flip side of that is a disability adjusted life year. So what's defined as a disability and quality, and then multiplied by time. So someone might have that 6 months, but where they have to be healthy in 6 months, where they have health, so, and then you can come up with a common denominator divided by a year.
Yeah.
That's sort of roughly this formula.
They determine the quality by asking, they do like a survey. How, like, would you rather have no legs, or
Yeah.
like, how much do you value? Would you rather have 5 years of no legs, or
It's 1
10
year,
or like whatever?
Yeah.
Isn't that how they do it?
That is, yeah. I don't know if you guys heard that online as well, but Teddy and Lawrence have sort of suggested the idea of a survey that talks about comparing health states in a way of sort of ranking what health state someone might prefer over another. And that is exactly right. It's called so what we use in the UK anyway is called the EQ5D, which is a survey that does exactly this. And so the way the questions are sort of stated are comparison questions. So exactly like Lawrence said. So would you prefer 5 years in this health state versus 2 years in health state Y? And ultimately, at the end of that questionnaire, they use that to sort of rank each health state and then give each health state a score between 0 and 1. So this is quite like reducing it right down to what the quality ultimately is, which is where one quality adjusted life year is basically 1 year in perfect health, or you could also say 2 years in half health. So this diagram sort of shows that in a bit of a sort of graphic format. So it's looking at the amount of time someone spends in each health state. So person A starts off in health state 1, then goes to 0.5, then maybe 0.4. And we look at the area under that curve basically to give us the number of qualities that that person might have. So it's quite a crude way of going about deciding the quality of life, and people answering these questions might disagree. Have you guys thought of any other things that might go wrong with this?
Isn't there a problem where humans good at habitualizing, like if you don't have any legs, the crude example, you kind of, your level of happiness returns after a while. So it's sort of a weird comparison. Like if they don't ask if you have this horrible health state, they ask you how much you value it because you're already in that state. You become used to it and you realize it's not as bad as I hoped it would be.
Yeah, definitely. So Lawrence mentioned that if you basically the transition to a health state is almost the biggest part, but once you're in a health state, people adjust to it quite well and would deem their quality of life very different to someone who isn't in that health state and is imagining life in that state. And as Lawrence put it, with or without legs. So yeah, it's a really interesting but widely used way of measuring health. But as you can see, they're not without their criticisms, and there are lots of additional add-ons that people have come up with in order to make them a little bit more sensitive. So for example, you can have disease-specific qualities or health-related quality of life scores. But yeah, so this is the one that's widely used and that's recommended by NICE guidance. But in sort of lower income countries, people more tend to use the disability adjusted life years as well. But we could do a whole presentation on just like this score alone, but we won't, not today anyway. So yeah, you might then be like, okay, so we can measure health. Assuming we've got costs, we can calculate costs. But how do we model the impact of an intervention over time and all the eventualities? So this is where Markov-chain models come in. Has anyone had experience with Markov-chain before? No, not yet. Not yet, hopefully. Pardon?
NCNC. Great.
So yeah, so Andrew Markov is the guy who like essentially came up with this a little bit a while ago. And his data set was poetry. So he used the letters in poetry as sort of a really big piece of data in order to study probability theory, basically. At that time, probability theory was just sort of used or applied in independent data sets. So Markov wanted to show that actually you can use probability theory in structured dependent data sets. So as you know, language isn't entirely independent. A lot of the sort of language has like dependency on what words were used before. So when you've got text prediction, that's essentially using the input that you've already put to predict the next word that you might want. So that's the structured dependency. And so Andre showed that you could apply probability theory in these circumstances. So what he did was he defined the state space, which is a finite set of mutually exclusive, completely exhaustive states. So he wanted to look at the transition between vowels and consonants in poetry. So he wanted to say, so vowels and consonants are the state space. So a letter can either be one or the other, and it cannot be anything else. So that's what the Mecke state means. And so we can also apply that to health states as well. So we can segment the population into certain health states, which are Mecke, and we can use Markov chains on those state spaces. But essentially, what these are sort of dynamic states as well. So they're sort of sequential over time, which means we can model state spaces over a long period of time. And stochastic, so they're based on probabilistic transitions, which can be presented as a transition matrix, which we'll talk about a bit later. So I've already talked about structure dependence, but the one key thing about Markov was that it's not that the data is independent. So we do depend on something, but the state that we depend on is the present state. So it's essentially saying that all the information we need is in the current state, and that holds all the previous states. So it really simplifies it from saying, okay, do we need to know every single previous state that this person's been in? To no, actually, we only need to know the present state, and we can stochastically predict sort of what might happen next.
I think this is I read about CMC markov-chain, Monte Carlo methods, etc. And this is the bit that I've struggled most to conceptualize, because like clearly it helps say you is well and disease state is unwell, and you go through steps. So how is it that only the memoryless property, where only the last state matters, the immediate last state matters? So that maybe this is not the right one, but if it's appropriate, maybe.
No, definitely. The memoryless thing, so Teddy was asking about the memoryless concept. So the memoryless concept was shown sort of that it technically it's not memoryless. It's saying that the memory is stored in the present state. So it's saying that if we get enough information from what they're doing right now, because what they're doing right now is dependent on everything else.
It contains everything's contains in that current state and for the next state.
Yeah, exactly. Which is difficult to imagine like realistically, because we might say, okay, you know, someone who's had maybe a diabetic foot and then gone on to have an amputation, and now they've got a different problem. That problem might not encapsulate all the past. But I think the thing with Markov chain is it's saying that, you know, in certain circumstances, we can model things in a memoryless sort of dependent way, where we actually do surprisingly get really accurate sort of modeling out of this, which might not make sense, but shown mathematically that, you know, most of the information is in the present state. So yeah, it's quite interesting. And they are used in lots of other applications. So there's different types of Markov chain. We're just going to cover like discrete time dynamic models, but there's also something called hidden Markov models, and that forms the basis for a lot of well-known modeling like Google PageRank, early large language models, speech recognition, Bayesian learning, deep learning, and reinforcement learning. So it's one of those things that has kind of been in the background of all these sort of exciting aspects, but this actual like structural assumption is helping us learn from like dependent data, which is such a key aspect in today's world. So yeah, back to health economics. So how do we use Markov chain in health economics? We essentially use it to model, as I said, health states. So if we're looking at maybe like a cardiovascular disease health state, it might look like, you know, healthy with risk factors, with one condition, with complication, and then with end organ damage potentially, or acute complication. So we essentially make a probability state diagram with health states that are mutually exclusive and completely exhaustive. So making sure that everyone fits into one box and one box only, and no one is left out essentially. So this example has an absorbing state, which is death, because as you can see, all the arrows, eventually everyone is going to die. Basically. Exactly. Once you're dead, you hopefully stay dead. And so if you ran this model like over a long period of time, all of your cohort will be in the dead state. So that's called the absorbing state. And so how long you run the model for is called the time horizon. So NICE guidance sort of suggests a lifetime horizon is the ideal, which means that if you start your model with 100 people in the healthy state and they've got an average age of 40, you'd want to run the model for at least 60 years, because that way you want everyone to get to that dead state so that you can model how many people are in each state at any given time. Pardon? Yeah, you can make some really simple ones, which I'll show you. But the really, really complex ones, I think. But surprisingly, a lot of this is still done in Excel, which like baffles me. But so I ended up doing it in R, which was a bit nicer in my opinion. But so each cycle essentially is an application of the transition probabilities. So what's the probability of moving to the next state to your current state sort of like classification. And so a cycle can be a year or like 6 months. So you're dependent on what you're trying to model, because it would vary depending on like what the event rate is. If something's quite acute, you might want to do a shorter cycle length. And then you trace the expected values across the cohort. So you can say, okay, in year 1, this many people were healthy, sick, or dead. In year 2, and then each year you kind of calculate who is predicted to be in what state. And this is where you can calculate your costs and qualities at each cycle level. And as I said, NICE has these like set of reference cases, so it's predefined state diagrams for certain conditions or certain pathways. And this is because, they're going to have to be doing economic evaluations all the time, every time a new drug comes out or anytime a new intervention comes out. So they want them to all be comparable, repeatable, and transparent. So this is kind of like what the transition probabilities might look like in a transition matrix. And this sort of top probability definition basically just says that the next state is dependent on the current state. And you essentially apply probabilities in this matrix and apply it to your state vectors. So essentially everything sort of each row has to sum to 1, because you've got a McKee, mutually exclusive, completely exhaustive sort of state selection. And then multiplying this by the current state vector and doing this repeatedly over however many cycles will give you your sort of modeling. So it's not like complicated. Yeah, exactly. Yeah.
You just done the 1 week. In your model, you can't go big sick to healthy again it's like a one-way transition.
Yeah, in this model, but you can model going the other way, but it essentially gets more and more complicated.
Get to like a quadratic computation spec.
Yeah.
Yeah, you could then have every permutation.
Yeah.
Also, another thing I found is that I'm not a statistician, I'm a jobbing modeler. Description. I'm sort of training to told not to discretize variables. So, like HbA1c, for example, instead of binning it and creating arbitrary cutoff, that you model a continuous variable. Then when you get to advanced topics like this, then you kind of divide people into different states. So how does that two marry together?
Yeah, it's more about, so this is more about being able to apply quality of life and cost. So when you're making your states, this is why NICE have their reference cases, because you want to say like, okay, this state have a similar quality of life and a similar cost. And so it's all dependent on, and also depends on what data you have, because you're not going to go out and do your survey just so you can get the qualities for your particular state. You're going to try and find some literature that's already done that. And then that's why I think NICE have come up with these predefined states to sort of help people and say, okay, there's already data on this. So it is kind of like a very, to be modeling such a complex thing, it's quite like they've applied quite, lots of assumptions onto it. There's layers and layers of assumptions, which is why this is not perfect. But I find it really interesting that this is how a lot of decisions are made. Or part of the decision is an economic evaluation, not the whole decision. This is just an example in R, so you can see it's like not massively complicated. It is matrix multiplication for most of it. But ultimately, you can then sort of end up modeling your state probabilities over time. So you can have a look, okay, so for this I think this is the example of the healthy sick or dead model. You can see that everybody starts in healthy, and then slowly over time, everybody ends up in dead, which is kind of what you'd expect. Yeah, sorry, I've made the probabilities quite high. But so this is you then sort of apply a different probability matrix if you've got an intervention, and that intervention might reduce the rate of becoming sicker, and might even reduce the rate of dead. So you would compare that to another sort of probability matrix and realize that, okay, maybe we've got less sicker patients, which means we've got less costs coming associated with that. And the way that's like done formally is this incremental cost effectiveness ratio, which kind of sums over the cycle the total costs per cycle, as well as the total QALYs per cycle, and compares the old with the new. But then you might say, okay, so we've run the model, we've got this incremental cost effectiveness ratio, but like, what does that mean? And how do we decide if that's actually cost effective? So this is where, again, NICE comes in. So you might have heard recently that the cost effectiveness threshold has increased. So this was quite like a big thing in the news. We used to have a threshold of 20 to 30,000 pounds that NICE would deem cost effective if it was below 20, and between 20 to 30 was sort of a grey area where they would consider it, and above 30 would not be cost effective. So that's £30,000 per ISA, per like health unit gained. And so now this has gone up to 25 to 37, so that is quite a big increase, which now means that potentially more medicines will be deemed cost effective. So what they use is they'll look at a cost effectiveness plane like this, and say NICE's cost effectiveness line is this dotted line. So anything to the right-hand side of that would be, and above this new treatment, more effective line would be cost effective. So this segment, and anything else would be not cost effective, essentially. But so almost everything lands in this top right quadrant, because if it landed into any of these, it would be quite obvious. You would use the old treatment in this case, the new treatment in this case. And this one doesn't happen quite often, but because most of the time the interventions that we want to look at are more effective, but also more costly.
I guess at the bottom right, it's too cheap.
Yeah.
Yeah. Yeah, this just doesn't happen because also the pharmaceutical companies and everyone will be working this out as they go along, and they'll realize, let's put the cost of the drug around here, so that they have to negotiate a bit. Yeah, exactly. It's quite interesting. But also, so as I mentioned, there's so many assumptions that underlie in these models, like all these parameters that we have to, the costs that we put into the model, the QALYs that we put into the model, they're not all like 100%. So they have a range, and we want to make sure that, at the extremes of the ranges of all these parameters, are we still getting the same, similar answer? So we do sensitivity analysis. And this is called a tornado diagram, which is a way to do a one-way sensitivity analysis. So this example is just a hepatitis example of comparing a new drug and an old drug. And it sort of shows that if we change one parameter at a time, which of these parameters are having the biggest influence on the cost effectiveness ratio. So this is using net monetary benefit, which is basically integrating the willingness to pay, so NICE's threshold, and integrating it into our cost of our ISA. So you can see straight away which ones will cross the threshold. So essentially, by just the cost of the drug in this case, by increasing the cost of the drug, it's basically making it not cost effective, and that's quite a massive skew. But you can see that everything else, even if we sort of vary it by its extremes, they don't affect the cost effectiveness decision or the outcome that we might make. You can also do two-way sensitivity analysis. So let's say the cost of the drug was varying, but we actually don't know how effective it is either. We can see in what areas is the net monetary benefit zero, which means it's not really cost effective, or even below zero. So that shows in the higher the drug costs and the lower the effectiveness is, it shows you exactly at what sort of cost. If say the effectiveness wasn't as good as we thought it was, it will say what exact cost do we think we should be paying for this drug in order for it to be cost effective.
Even 30,000, pretty blue for most of it.
Yeah.
Yeah, so that range, I think.
Yeah, this example, this example I don't think is a real example. I just made this one up. But yeah, that's basically how you use that. But there's also the event in which, say, we had all the parameters were varied. So you can see here we did one parameter at a time, two parameters at a time. But what is the probability basically of this intervention being deemed cost effective? So we can do a probabilistic sensitivity analysis. So what that involves is repeated random sampling from the probability distribution function of each parameter. So that's to represent the uncertainty in that parameter. We often use the gamma distribution for costs just because of the way, this one's in the bottom left corner, of the way it nicely models costs generally, compared to the beta distribution for like quality of life essentially, which is almost like a normal distribution, but it never reaches zero. And we will repeatedly use random random variables from this distribution to model each parameter, basically just to highlight that it's all based on probability. And although we're taking the mean in our actual base case model, it could be any of these ultimately. And so this gives us what we call a Monte Carlo simulation, where we randomly sample from the probability distribution. And we can do this over thousands of times to produce a cost effectiveness acceptability curve. And so what this essentially shows is on the y-axis, it's what is the probability of it being cost effective. So after running it 1,000 times, for example, how many of those are sort of on the what is the probability basically of each price of it being cost effective. So say at a willingness to pay or a cost effectiveness threshold of £20,000, what is the probability that the intervention falls into that top right hand corner of cost effectiveness? And so yeah, you can model like different willingness to pay thresholds just to show that it really does depend on how we value health. So by setting this threshold higher, it's a massive change to what will happen. Yeah, so essentially with all this uncertainty, how can we be sure that it's cost effective? So this is sort of showing again on the cost effectiveness plane that over 1,000 models, our single model might look like it's here on this red dot, which is well below the willingness to pay threshold. So it looks like it's cost effective, but actually over 1,000 times, almost half of these, or just a quarter, are on the left-hand side of the willingness to pay threshold and will be deemed not cost effective. So it is just a probability at the end of the day. There's no certainty in these models, and they are upheld by a lot of assumptions. Okay, so I hope this question might be a little bit easier now. How would you pick between these two different interventions with completely different costs and outcomes? So from a health economics perspective, as I said, this makes up only an element of the decision-making process, but according to NICE and their technology assessments, this is sort of one of the biggest parts and most important parts as well, that they assess technologies or interventions on. But as I said, yeah, there's a lot of assumptions, some facts, and again, lots of value judgments. So yeah, you might want to ask, like, what assumptions have we made? are all collies equal? So that was a question that was asked like maybe a couple of years ago, because they introduced what are called severity modifiers, where for some certain health states, you can times the QALY by 1.7. That's the severity modifier that they've used. So they've deemed it essentially, more important, which is another sort of
Like losing one leg is like 5, but losing second and not 10, but maybe 20.
Yeah.
No, you can't do it.
Yeah, exactly. Yeah. And I think things like end of life, anything that's end of life can have a modifier applied to it. But yeah, another, you might be wondering, can we realistically capture the wider societal impacts? We're making like a really narrow focus on these interventions here, and excluding maybe the impact on carers or family or someone's job, and the impact that they will make in the workplace. So it is quite a narrow focus that we look at, but there's also some ethical, moral choices behind our decision making. So the willingness to pay threshold, although it's very politically driven, it is ultimately an indicator of our morals. And also the difference between technology assessments and highly specialized technologies. So NICE have a completely different willingness to pay threshold for highly specialized technologies. Like it's much, much, much higher. And how we define these highly specialized technologies, which are usually like ultra rare conditions and
Gene therapy.
gene therapy. Yeah, exactly. And we haven't talked about it today, but weighting is a huge thing. So like NICE recommend a 3% discount rate, which basically means that over time, any QALYs that are gained, if they're gained in 100 years, we will weight them less than if a QALY is gained today. So we inherently, in the way that we do our methodology, we sort of give a higher weighting to interventions that work quicker, which is interesting because if you think about preventative interventions, those will automatically be given like a discount because a lot of their improvements in QALYs will be a lot later down the line. So that again is quite an interesting sort of way of approaching these assessments. That's basically the end. I hope I'm okay with time, but this is Garkov, which is Garfield Markov. So someone's gone and made some comic strips with a Markov model, which basically uses the whole Garfield script and randomly assigns the speech bubbles, which I thought was really funny. But yeah, another use for Markov modeling. I hope you enjoyed. Happy to take any questions.
Thanks. Actually, I missed a comment by Marcus about predicting what comes after sequence of events, and
Sorry,
I,
what was that?
I lost the context of Marcus's comment about half an hour ago. I just saw it. Marcus,
sorry,
if
it
you
was-
still want to ask this question,
No,
please.
that's all right.
go
I think it
for
was
it
just
now.
a question around what Markov chains
I
are.
think
and
you're
I was,
muted.
can you hear
Oh,
me?
yeah.
Yeah, sorry, I was just trying to sort of answer what you meant by Markov chain. So yeah, thank you.
Oh, nice. Sorry, we missed that. Yeah, exactly. So predicting what happens after the current state of a sequence, which is after a sequence of events. Yeah, that's actually it. Nice.
I have 2 questions. Thank you so much for your interest. I read and want to implement markov-chain for many years. I've never really the stomach, the full gamut of it. How do you find adapting to it?
Yeah, I think in general, I found adapting to the health economics perspective really challenging, because it is a different way of looking at things, like the QALYs and the sort of the uncertainty and the the probabilistic nature of it. But I kind of found it helpful that we've got like such a structured, rigid way of like going about how to analyze this, and it's comparable and it's transparent, and although it's full of assumptions, that's also very transparent. So I think I found it a completely different way to look at things, but also like a nice structured process to go through, if that's helpful.
I think the follow-up question, if no one's any, please stop me. I The follow-up question I have is that in the resampling Monte Carlo simulation example, right? The key assumption that resampling don't affect the underlying distributions of the active sampling. Now that's not always true in real life, right? So
Yeah.
you might get asked about a health intervention, and that might put people's mind, and they might seek healthcare and so on. So how do they solve that in real life? Do they use a fudge factor, or do they do more modeling?
Yeah, so I think you can also do there's another technique called like micro simulation as well. And because there's a lot of heterogeneity in populations and health behaviors, micro simulation is another way to model states, but instead of doing it at a cohort level where you say, okay, on average, 70% of the population will have become sick in 1 year or something. Micro simulation does it at an individual level, so it's not like a cohort level, and that kind of can take into account some of the nuance. But still, I think still, I'll be honest, there's like the more I learn about stats and the more I learn about modeling, there's just assumptions everywhere. Yeah. The girl.
Thanks, Jazz. Really interesting. So can you give us a couple of examples of where this is being used? You mentioned drug companies use it as part of their model to decide what drug to get into the market. Does the health system as well use it, for example, NHS England or Department of Health or whatever, to decide what type of treatment they're offering free on the NHS and which bit is, yeah. So can you tell us some use cases that might use this methodology?
Yeah, so one thing I've been looking into at the moment is treatments for chronic kidney disease. And so recently, or in the last few years, so a treatment called sGLUT2 inhibitors, which are widely used for diabetes and chronic and CVD, cardiovascular disease, was put under a technology assessment by NICE. And so NICE had basically used an economic evaluation to say that, oh, this treatment is cost effective and valuable to patients, and now it's part of the NICE guidance. So NICE regularly use it to write their guidance and use it as evidence to write guidance. And I think for heart failure, it was sGLUT2s were also used in a technology assessment to recommend it as one of the like pillars of care for that as well. So yeah, I think as well as outside the pharmaceutical realm, it can be used for sort of more complex interventions as well. So public health interventions, although I think maybe in a less sort of structured way, because I think NICE predominantly uses it in the medication work
So this
realm.
is the methodology for standard kind of.
Yeah, exactly. Yeah, it's quite interesting to dig into the background of it. But also there's a thing where NICE do the public can sit on technology assessment appraisals. So if you're interested, NICE have a website page where you can say, oh, I'm a member of the public and I'm interested in attending one of these tech appraisals, and they'll go over the economic evaluation and all this stuff with members of the public sitting there, so you can potentially watch one happen.
Marcus, you have a hands up?
Hi, thanks for that, Jasjot. Just wanted to ask you, I mean, obviously it's so interesting to learn about this at a very macro level, but at a micro level, operationally, so I work within cancer and surgery. So you feel like there's a use case there at, an operational level as well, where you get a lot of referrals for cancer and then being able to sort of predict, how many of those then convert into chemo surgery and, helps with a lot of demand capacity planning. I don't know whether there's any sort of examples that, something like this has been used at an operation level, because we do hear a lot of clinical data scientists around, but nothing more sort of operational in nature that sort of would help us with some of the challenges that the NHS frontline faces.
Yeah, that's really interesting. That was actually something that I wanted to look into doing, because I think the use cases are much like far and few between. But I know, for example, that I saw someone had used Markov modeling to look at the transition between living circumstances. So if you're living alone compared to living with someone, compared to living with someone with a chronic disease, and also just like like tracing sort of your how your quality of life or cost effectiveness of certain interventions changes depending on that like kind of health states, but more like living states. So I think there are definitely more applications out there, and I think operational applications like waiting lists and care pathways is probably a really good one. Something I've not fully delved into, so I'll let you know because it's definitely something I want to look at.
Maybe you should organize a tutorial.
Yeah,
To the hands on.
That would be cool. Yeah, maybe we could go through a work.
Do you think there might be appetite if there's a tutorial on example of how to set markers model from scratch?
There's a lot of appetite, mainly because on the front line, we have various levels of clinical complexity, and because of how we access data. So unfortunately, we just have access to secondary care data, which with Epic, there's a big wealth of data that's available, and being able to sort of say whether a patient is complex or not, even a very simple thing like that could really make a big impact on how clinicians are able to deliver personalized care. So yeah, there's a lot of appetite out there, but it's just I think everyone's so stretched, and then we have this wealth of data that's available, but not enough skills to sort of bring that together and bring in the insights to help them see more patients and deliver quality of care. So yeah, definitely something to work on.
I think you're saying really well from when you get that transition probability matrix to doing the simulation, but I'd be curious how you wrangle the data to get into the transition probability matrix. That is the real money to decide how you count probability.
Yeah, no, yeah, massively. I kind of maybe skipped over that a little bit because it's quite a lot of looking at previous literature, or a lot of it comes from randomized controlled trials, which is interesting. So we apply and often it's quite different to what happens in the real world. So a lot of our economic evaluations are based on like trial data and trial effectiveness. And one of the things I guess is becoming more important is real world effectiveness. And there's so much more heterogeneity in the real world. So yeah, I can't remember what your question was. Sorry, I kind of
I just found a tutorial.
Oh yeah.
How you wrangle the data.
Yeah.
Telling the juicy bit.
Yeah, the juicy stuff. Yeah, real world data definitely really, really important and would be cool to wrangle with to do something like this.
Okay. Anyone else got any questions or comments? Please share. Otherwise, if you scroll a little bit above, there is a feedback form. I'll be most grateful if you could fill the feedback form, please. But otherwise, I think this is the end of our talk today. Thank you, everyone. Next month, we got actually Narinder Kaur. She's actually on the meeting, so Narinder's presenting next month. So look forward to seeing you all again very soon. Hi, Narinder. Good to see you. Looking forward to your next talk in a month.
Thanks, everyone. Thanks,
Thank you.
Thank you. Bye.